Hello and happy Friday. Thank you all for joining us today. Today's webinar is being recorded and will be posted to our website following the conclusion of the Finance Series webinars. The recordings as well as the slides will also be sent to all participants shortly after the series is complete. Please note that there will be a PDF of today's presentation that's going to be added to the chat box shortly. The Finance Series does qualify for continuing education credits. So if you would like to receive credit for the Finance Series that you attended, we will be sending out an email upon the completion of the webinar series, which you may fill out to receive those credits. In this session, participants will get an overview that's geared towards critical access hospital senior management to help decision makers to better understand rural hospital performance and the linkage between finances and service delivery. Before we proceed, I just want to take a moment to introduce myself. My name is Shannon Sari, and I am the consultation team lead with the National Rural Health Resource Center. And the center, which you'll hear us refer to, is providing this webinar today. The Delta Region Community Health Systems Development Program is funded by the Federal Office of the Rural Health Policy in collaboration with the Delta Regional Authority. We do ask, if you haven't already, to please connect your video feature by selecting the camera in the lower left corner of your screen. We ask that you remain muted unless you have a question. And if you were one of those folks that dialed in through your phone, if you do want to come off mute, if you press *6, that will unmute your line. You can also communicate through the chat box, which is located on the bottom ribbon of your screen, as Caleb and I will be monitoring that. If you haven't already, please take a moment to type your name, title, and organization into the chat box so we know who's joining us today. Next slide, please. Thank you. The National Rural Health Resource Center is a nonprofit organization dedicated to improving health in rural communities. The center does provide technical assistance, tools, and resources to support rural providers in the 5 core areas that you see listed on the screen. Next slide, please. The center is committed to diversity, equity, inclusion, and anti-racism. For additional resources, please visit our center's website to assist with your organization's commitment. Next slide, please. Thank you. We do have 2 pre-polling questions that we would like you to answer before we get started on today's session. Your response options will range from confident to unconfident, and we have 2 of those questions. As you all are doing so, it is my pleasure to introduce today's speaker. With more than 27 years of experience in healthcare financial management and consulting, and nearly 20 years with Stroudwater Associates, Eric's passion for sustainable and accessible rural healthcare has driven him to assist hundreds of rural hospitals, rural health clinics, and physician group practices in improving financial and operational performance, as well as developing strategic and operational plans. So on that note, I am going to hand it over to Mr. Eric to get us started.
Great. Thanks, Shannon. And appreciate you guys all joining and allowing the flexibility to get this rescheduled from Thursday to Friday. I know Friday morning to better understand critical access hospital kind of economics is something we're all interested in. And anyway, we've got a lot of content. For those of you who were on the call last time, that we said we had a lot of content. This presentation has even more. So we're going to see if we can't get together and get it out in the next 45 or 50 minutes or so. So This is actually interesting enough. This is a presentation that I developed probably, over 15 years ago. And what's happening is as I'm traveling out there around the country, visiting rural hospitals, the questions that we this presentation was geared to address are coming up over and over again. And so I thought it was really important to have, get this content out and start having people talk about it. And so that's why I thought it was going to be an important part of this finance series. So what are we going to do today? High level objectives. We're going to look at the high economic overview. At the 30,000 foot level. Then we're going to drill down and answer some very specific questions that have come across my desk over the last 25 years. And then we're going to wrap up. So that's kind of the agenda for today. I think that the objectives is to understand this economic framework. And I've been giving a talk on kind of the three key attributes of financial success in a hospital, in a critical access hospital. And those three kind of key attributes of successful rural hospitals is one of them is this fundamental understanding of the economics and the interplay between the service delivery and economics. The second one is around having an abundance mentality, and the third is a measurement culture. But this presentation is really front and center in one of the three key attributes of what I consider successful rural hospitals. We'll understand some of the drivers. What are the drivers of critical access hospital profitability? And then really, my number one objective is to have you asking more questions when we get done with this presentation than you had coming in. And I do believe that transformation begins when we change the questions being asked. And this presentation is about changing those questions that we're going to ask. So high-level economic overview. And here's where people are going to start dozing off. But this is so fundamental to the profitability of hospitals that if when folks start looking at the cost structure, and we distinguish variable costs from fixed costs. And think about variable costs as expenses that change with changes in activity, very specifically. And versus fixed costs or mixed or step fixed costs that really don't change. If we admit a patient today, and we think about what changed, how much did our costs increase when we admitted an additional patient today, or had someone come through our emergency room today. And when we start thinking about that versus those that are more permanent, and I would essentially in most cases lump staffing into that more permanent fixed or at least step fixed costs. This point about rural hospitals having inordinately high fixed costs relative to revenue is just such an important concept as a baseline understanding. And because of this high fixed cost nature of rural hospitals, it focuses on several areas: volume, unit price increases, and then how do we take out fixed costs if we have to? These are kind of the key areas, the keys to the kingdom around success. It's interesting. This was a couple of years ago. I was working with the Pennsylvania Rural Global Budget Model, and one of the exercises that we were doing, working with another firm, was looking at the general ledger and taking all the expenses of these hospitals that were going to participate. And when we broke the general ledger down, what we found was only about 15% of the costs were truly in that variable nature, which means 85% of costs are fixed or step fixed. Now, when that happens, let me just, this graph is going to be really important. We're going to keep going back to this. The x-axis here is volumes. So it's low volume, 0, and then high volume is out to the right. And I hope you can all see my pointer. And then on the y-axis, you have dollars, right? $0. And then high dollars. And this is really important, this play right here. So when an organization has high fixed costs, what that means is at 0 volume, so no volume, costs start up here. Think about that as your parking lot at your hospital at 8 o'clock in the morning. We have it's 3/4 of the way full, all with employees, and in the patient parking lot, there's no patients. That's high fixed costs. Just doing the parking lot test. So what happens though is we admit a patient today, or we admit somebody, or someone comes to the emergency room, our costs go up a tiny bit. So what happens is as volume goes out, our total costs go up, but at a very low level because so much is fixed. On the revenue side, at zero volume, we have zero revenue. And as we go up, we admit that person in our hospital, we get $2,000 per patient day, or in the emergency room, we get $500 when our costs went up nearly nothing. So as volume goes up, there's a much steeper pitched line of revenue. So we admit somebody, it's say $2,000. We admit somebody else, it's $4,000. And yikes. So what happens is this line goes up much steeper. Now, I will tell you, as a critical access hospital, tipping my hands a little bit, this revenue line isn't necessarily accurate. Let's assume we have two patients, one Medicare, one non-Medicare. The line actually would start here, right where my pointer is, and it would go up. And then once we get past this break-even point where we become profitable, the curve would go like this. In other words, cost-based reimbursement, all of your cost base, well, that's Medicare and Medicaid, if you're in a state that pays on a cost basis, to some degree, your revenue line is tied to your cost line. It's your commercial line that's this very steep pitched line. In aggregate, they come up with a blended amount. So anyway, that's the cost structure overview. And here's some food for thought. Maximizing cost benefit does not result in profitability. Right. And so many times I hear people saying, boy, we need to maximize our Medicare rates. That is not necessarily a profit maximizing phenomena. Like any business, profits are equal to revenue per unit less cost per unit times units of service. Revenue is per unit is total revenue divided by units. Expense is our cost divided by total units. And the key to achieving profitability, there's three, and then possibly a fourth, and we'll talk about that, is we have to reduce total costs, we have to increase fees for non-cost-based payers, and then increasing units of service. And we're going to show you how that plays out. So again, high level economics, that's kind of what we're dealing with. Now we're going to get into some questions. And what we're going to do is we're going to answer these questions through economic modeling. And these are interesting comments or questions that I've heard as I've traveled around the country the last 25 years. And we're going to show how an economic model plays out. So a Vermont critical access hospital administrator, as where I was yesterday, our cost-based payer mix is nearly 60%. If we increase our expenses, we generate more revenue and margin. And I want you to think about that. I want you to think about what that question is and that statement is, and just think if you agree with it or disagree with it. The second one, a Mississippi Delta critical access hospital administrator. Why do we want to cut expenses if we lose revenue? I want you to think about that. New York Critical Access Hospital Administrator. So this was the first critical access hospital I ever visited back in 1999. The CEO of this hospital, his inpatient Medicare cost-based payer mix was 92%. So keep that in mind. He was running a census of 3. The hospital was losing money to the point where the big system hospital said, if they lose any more money, we're going to close them down. And the CEO's entire strategy was to increase his inpatient per diems from 3 to 4, knowing that he would generate $1,500 per day. He was doing the math and saying, one extra day times 365 times 1,500 is $700,000. All I have to do is this, grow census from 3 to 4, and we're going to be financially successful. I want you to think about that and see what he's saying to see if you agree with him or disagree with him. A critical access hospital administrator from Illinois. It takes 4 outpatient encounters to equal 1 inpatient day. We're going to focus our efforts on inpatient services. A couple more questions. This was I was out in Anchorage, Alaska, several years ago. And an administrator, I was talking about how important, kind of imaging services are to the profitability of a critical access hospital. And he raised his hand and he said, I don't know what you're talking about. These tests are costing us $800. We're only getting paid $500. You're telling me that you want to grow imaging, but we lose money every time we provide this service. Again, I want you to think about what he's saying. Here's another Mississippi co-administrator. Our Medicare per diems are $1,400. My commercial per diems are $950. We're going to exit commercial and focus on Medicare. What do you think about that one? And then finally, the last question, and another Mississippi Delta co-administrator. Reference lab tests reduce our Medicare revenue. We want to get out of this business. Again, think about that. And we're going to address these through financial modeling. So here are the questions we're going to look at specifically. How do we generate cash reserves? How do we generate profit? Why do we cut expenses if we lose revenue? We're going to address this question of Medicare inpatient per diems are higher than commercial per diems. What should we be focusing on? Should my hospital be focusing on inpatient volume or outpatient volume? How do we want to look at non-hospital businesses like home health or skilled nursing facilities that are managed by our critical access hospital? Is that a good thing? And to answer these questions, we're going to start off with this hypothetical model. And this is one, see if we can't, try to kind of star this slide because it's going to help build the case for a lot of answering the questions that we just came up with. So you just from an expense perspective, these assumptions right here on an inpatient, think about the variable costs per day are $250. In other words, pharmaceuticals, food, somebody's admitted today, we're going to spend some additional money, but not much. On a swing bed side, we've dropped that down to about 150. And then we assume the fixed or step fixed costs related to this inpatient unit are around $6 million. On the outpatient side, we assume the incremental variable cost. We admit a patient presents in our emergency room. We assume incremental expenses for $50 and outpatient costs, total fixed or step fixed outpatient costs are $10 million. That's on the expense side. So let's see if we can remember some of that. On the revenue side, the acute revenue per day for non-cost-based payers is $1,400. And again, it's non-cost-based. It's just your commercial payment. On the SNF side, it's $500. These aren't going to matter. On the outpatient side, an outpatient revenue per unit for non-Medicare, and note, I really want to stress non-Medicare commercial is $200. What's important is not necessarily what it is, other than we want to keep the interplay between the revenue of $200 and the variable expenses of $50. That's what's important to understand. The next thing that's important to understand is the payer mix. And generally when I build this model, I'm assuming equal swing bed and acute care census. So on the inpatient side, for acute care patients, 70% is cost-based. For swing bed SNF, the Medicare, it's 100% cost-based. So to some degree, in this hospital's case, the combined cost-based payer mix is about 85%. On the outpatient side, and this is a hospital with, we probably Medicaid is cost-based as well, because the cost-based payer mix on the outpatient side is 50%. That's the assumption we're going to use in this model that we created. And again, the purpose of the model is to test some of the questions and the assumptions. So now let's see what happens when we vary assumptions with this model. Same model, those same assumptions. And what we've got is, again, here's high level, this fixed cost is $6 million. Variable costs is noted here. And we're going to start off with a census of 4, and we're going to go to a census of 9. And what we see here is that our fixed costs remain fixed at 6 million. Our variable costs increase as volume increases, but you can see that the slope of this cost line as volume increases is very shallow, just like that hypothetical, that high level graphic that we showed earlier on in this presentation. Very shallow sloped cost curve. On the outpatient side, similar type analysis, $10 million worth of fixed costs, and then we assumed $50 of variable expense per unit of service. And down here, you'll see we went from 30,000 units of service to 80,000. And again, it could be defined as imaging tests, emergency room volume, clinic volume, whatever it is. But you can just see, once again, you have a very shallow sloped expense curve. Now, here's where things start to get interesting, because this is looking at unit costs. Again, we defined unit costs as total expenses for this inpatient unit divided by total units of service. And what we'll see is at low units of service, in this case 4, the total unit costs are about $22.50. Let's say they split the difference here, $22.50. And as we increase the units of service on the inpatient unit, our unit costs come down and down and down and down to the point when we get out to a census of 9, our unit costs are in the probably $1,100 range. So they got cut nearly in half. Now, what's interesting is that the variable costs, right, the blue, stay constant at $250 a day. The red is your fixed costs on a per unit basis start very high, because the the $6 million of fixed costs are divided by a small base of volume. And as we increase the volume, those costs get diluted over higher units of service. Same thing applies on the outpatient side. So we can it's the same type of thinking. $10 million of fixed costs, which was the assumed outpatient costs, divided by lower units of service, results in a very high fixed cost per unit of service. Now, this one, again, when you get these slides, slide 23, write this down. To me, this one slide tells us everything we want to know about being profitable as a critical access hospital. This one slide, and let me explain it to you. So first, the blue line, that's easy. The blue line is your commercial revenue, your price your commercial payers are going to pay on average for a hospital, for an inpatient day. And it's at any volume, it's the same amount. It's $1,400. And that was one of the assumptions in the model. The pink line is your cost per day. And your red line is your Medicare, your Medicare revenue on a per day basis. And you'll note that your cost per day and your Medicare revenue per day are essentially equivalent. I think I built in a 1%, just for the Medicare's 101% of revenue. I didn't back off the sequestration. But what you see then is when we start saying, okay, where's this unit break even? Well, that's easy. It's right here at 7.25, census of 7.25. This inpatient unit breaks even. And then I'll ask you the question of, well, why is that the case? Well, it's the case because it's the point where your unit costs are down below what the third-party payers, your commercial payers, are willing to pay. As you can see that. And so, but it really isn't anything to do with Medicare, because Medicare is going to pay you whatever your costs are. And so, oops, let me just go back. So when you think about this, and what jumps out is that in this approach, there's this highlights 3 approaches to improving profitability. The first is the blue line. If you negotiate higher rates, let's say you negotiate a $1,700 rate with your commercial payers, what happens is this line goes up and your break-even point goes from where it is here at 7.25 to now approximately here, about 5.5. Or at 7.5, you can create profit on the difference between, you negotiated $1,700. The difference between 1,700 and this line right here multiplied by your commercial days is your profit. So step one of profitability, this blue line, raise this blue line by better negotiating. Step number two, cut expenses. If you cut expenses, let's just say this line, right, this expense at any unit of service, if you lay off 4 nurses, or you can't recruit 4 nurses, better off, and your total costs come down at any volume. So this curve that you'll see, your cost curve just dropped. It's down to here. So again, your break even is going to move back, or you create profit at the same current at this 7 and 7.25. And the third is to increase volume, right? Because as you grow volume, you push out your volume. What happens is you drive down your unit costs to the point where you can make a margin on your non-commercial business. And again, I've never mentioned Medicare because Medicare is not going to, you're not going to have margin created by Medicare. Medicare is going to pay you your costs. However, and this is the most important thing I'll say, is that Medicare, especially when you're inpatient unit, when 85% of it's Medicare, when you combine your swing bed and your acute, 85% is cost-based. So the Medicare volume is absolutely essential to driving down your unit costs so that you can be successful on your commercial business. So this is a really important slide right here, and it really tells us everything how to be profitable. Same thing on the outpatient side, same exact thing. So we're just going to save some time, we're going to jump over that. And so again, now let's look at that first question. How does my hospital generate cash reserves or essentially profit? And again, using that same slide that we just looked at, it becomes very clear what we have to do. We have to either increase price, push out volume, or cut expenses. And same thing for the outpatient side. And so I set this up to say, okay, let's take a look at each of those strategies. Let's look at what happens when we decrease expenses. So here's your expense line, the blue line right here. Here's your revenue line. This is much more appropriate for a critical access hospital because it starts halfway up. So here's your break even at this unit of volume, that we break even. Let's cut expenses. So we just laid off those 4 nurses, or frankly, they left and we can't replace them because there's such a nursing crisis going on right now. But something else happens. Our revenue just dropped because a significant portion of our payer mix is cost-based. So if we cut expenses, we will cut our revenue, the portion that's cost-based. So, but still, even with that said, our break even drops back to here, or our profit at that past volume is the difference between our costs, our revenue times unit of service. So that's strategy number 1. Strategy number 2, increase fees. And increasing fees, can take on a number of different characteristics. One is, update our charge master, make sure our charge master is accurate. Renegotiate third-party payers, have better revenue cycle functions, have a cost report that says we're getting paid the full amount from Medicare. And so what we do that, let's just kind of play off with this, our break even here at when our revenue curve, our cost curve, break even is here. Let's increase price. Let's increase fees. And what just happened is our break even went from here back to here. Right. And so we can see that. And so again, strategy number 2 is absolutely critical. And frankly, when When I was just yesterday or Tuesday and Wednesday, I was at a critical access hospital in Pennsylvania. And, when we sit down to talk to them and we say, hey, there's really 3 ways to improve your performance. The first is kind of figuring out ways to grow revenue. The second is increasing your fees or getting paid better for what you do. And the third is cutting expenses. But we spend about 5% of our time looking at expenses because most rural hospitals have been forced to be efficient for years and years and years. So there's not often a play there. So anyway, the third is increased volumes. And this one, I believe, is the home run opportunity. We've talked about it in the prior finance series presentations. And the reason why it's such an opportunity for you is that generally about 65% of the business in your community drives right by the front door of the hospital for services in bigger cities. That 65% is an opportunity. Now, we're not going to get the cath labs and we're not going to be doing neurosurgery or anything like that. But there's a significant chunk between those services and what's currently provided that is the opportunity. And if we are able to increase our own market share by 5 percentage points, that's a 15% increase in volume. And so again, strategy number 3, increase volume. So we start with the volumes where they are there, and that's where, that's the break even. And as we push out volume, what happens is our costs, the shallow slope cost curve versus the more steep sloped revenue curve, creates a profit as we push out volume. Now there's one more opportunity for you, and this is one you're gonna scratch your head at, and may push back on me a little bit. But it's grow non-Medicare business. And then what I want to be very clear is I'm not saying don't focus on Medicare business, but growing non-Medicare business is a margin opportunity. And there's a reason for that. So the reason is if we look at this first graph here that I'm circling right now, and we just look at Medicare cost-based revenue. Sorry, who did that? Your costs, again, shallow slope line. Your Medicare revenue, if Medicare is 50% of your total business, it's going to have the same slope as your cost curve. So it's going to go up on a very shallow sloped revenue line. If we want to, essentially reduce our commercial business or increase the percentage of Medicare, what happens is it will shift up, but we will continue to have revenue below costs. And there was an interesting, years ago, I was at an interesting critical access hospital out in Colorado, where they essentially, told their medical staff, really, we're just going to focus on Medicare. We're just going to focus on Medicare. Blue Cross, send those to the big cities and all of this. And so when I got out there, the reason they called me out there is they were losing money. They were running out of cash, and they didn't know what they were doing because they thought that they were focusing on the right thing. And once we kind of shared with them, kind of this curve right here and the understanding that Medicare is important to cover your costs, and commercial is important to generate or margin. And so again, it's that steep sloped. You admit somebody in the emergency or a patient, a commercial payer comes in, and you generate $500, but for costs of $50. And you do that again and again and again, and it's a very steep sloped relative to curve. So growing commercial business, I think, is important. So again, if we are looking at this answers to question 1, how do we generate return? It's these 4 approaches right here are the keys to the kingdom for critical access hospitals. And again, I'm going to say this, I'm not saying reduce the importance of Medicare. Medicare is such an important volume source that allows us to drive down unit costs to put ourselves in a place where we can be successful for our commercial business. Without Medicare business, or if we reduced our Medicare, our unit costs would increase, which is making it very difficult to make money on our commercial business. That was the answer to question number 1. The next question was the administrator that said, why do we want to cut expenses if we lose revenue? And so let me explain this. So this was a hospital that was running an average daily. So this is current state, this top part. And then below is the scenario that, so let's, so this is base state up here. And then down here is let's reduce our routine expenses by 15% without impacting volume. So up here, what we've got is we've got our patient days broken out between Medicare and Medicare payer mix, Medicare days, non-Medicare days, the rate per day for acute swing bed observation. And here are your total routine costs. Total routine costs, if you divide them by total days, you come up with a rate per day. Medicare is going to pay you that rate per day, the $431 times their days, they're going to pay you this amount. Your commercial payers, you're going to multiply your commercial days by the rate per day to come up with your commercial reimbursement. When we add the Medicare revenue to the commercial revenue, we come up with total revenue. Our routine costs are 1.9 million. So on the routine side, this hospital generated a margin of $230,000. Great. Let's now reduce our expenses. So you'll see it's the same model, no changes in volume. But what we did is the yellow highlight is we carved out 15% of our costs. Now, if we look what happens, Medicare revenue is going down. Medicare revenue, the rate per day, we just dropped from $430 a day to $366. Medicare revenue went from 1,585,000 to 1,347,000. We cut our Medicare revenue, absolutely, but our commercial revenue stayed constant. When we add them up, total reimbursement is 1.9 million now. Routine costs are 165. The profit on the inpatient routine services is now 53,000, is 283,000, which is 53,000 more than base case. So, but here, bottom line here is by reducing our expenses by $290,000, we ended up generating about a 53,000 improvement in our profitability. So back to this question, why do we want to cut expenses if we lose revenue? And here are the observations that reducing routine costs decreases Medicare revenue, assumes volume remains constant. But Medicare margin remains constant. It's zero. Reducing routine costs decreases unit costs, but the non-Medicare margins increase. So for all the days that are non-cost based, we've actually increased the profit on those days, resulting in a $52,000 increase in profitability of this hospital. So the answer here to this question is reducing unit costs decreases Medicare revenue. It does. It definitely decreases Medicare revenue, but it improves the margin. The next question we want to look is, if our Medicare per diems are higher than our commercial per diems, should we focus on growing Medicare and, diminishing commercial, reducing, let's not focus on that. Let's really just focus. So again, this is looking at Medicare per diems, and Medicare per diems, as we talked about on that one slide 23, that is so important. Medicare per diems are not what you receive on an ongoing basis all during the year. That's an estimate of what your per diems are going to be at the end of the year. But depending on where your volume ends up, those Medicare per diems could be higher than what you're currently receiving on an interim basis, or lower than you are actually receiving currently on an interim basis. And so much of it depends on your cost structure, which is driven by, in most cases, your volume. And so, it's Medicare per diem. The difference between interim per diems and settled per diems are very different. As volume changes, your Medicare payment per day increases or decreases. So one of the things that we did to help answer this question is said, okay, let's do this. Let's look at our inpatient unit, and all of the volume growth from our inpatient unit is going to be Medicare. It's going to be cost-based. And what happens to our costs, which is the pink line, and our revenue is the blue line as we grow volume. And what you'll see is that as we grow our Medicare volume, our revenue doesn't go up very much at all. It stays almost constant with the cost curve, which makes sense because in the model, we defined our inpatient unit is 85% cost-based. Now let's turn around and let's grow non-Medicare inpatient volume. And what we'll see is that there's a significant more profitability created. And again, once again, that gets back to the fact that as we drive down unit costs with higher units of service, that profit, there's an increasing profit on each of those days. Here's another example of outpatient versus growing outpatient. So in this case, there was and this was an interesting story. It happened years ago. A call from a critical access hospital in North Dakota, in which Blue Cross Blue Shield was underpaying the critical access hospitals relative to costs. And so one of the questions the CEO wanted me to help answer was, what happens if we just went non-par with Blue Cross Blue Shield and really just said, no, we're not going to take your fee schedule. We're not going to see your patients. And he wanted to test the impact of doing that. And so again, we set up a very similar model. So the test model, what we wanted to do is say, what would be the bottom line impact of 50 additional Blue Cross radiology tests when Blue Cross on average was paying $82, so $82, but the unit costs of the inpatient unit were $98. So let me explain. So here's the units. There's 1,200 units. Medicare payer mix is 33%. So the Medicare units are about 400. The non-Medicare units were 796 times 82. Other revenue was 65,000. Here was the fixed costs. Here are the variable costs. And again, what we assume, variable costs of one additional radiology test of $10. If you think about it, we're not going to change our staffing model. It's really just electricity, and it's not a lot of cost for one additional imaging test. And so what we said is the total radiology department costs were $117,000. If $10 is the assumed variable, then it's the 11.5. Then your fixed is the 105. It's the difference between the 117 and your variable cost is your fixed. Total units are 1,200, resulting in unit costs of $98. Medicare is going to pay you that $98. So they're paying a higher rate than Blue Cross Blue Shield. Medicare payment, bring it over. We're getting paid $65 from commercial. The outpatient costs are here. This imaging department loses $13,000 at current state. Now let's change it. Let's generate 50 additional Blue Cross Blue Shield tests. Now note that Blue Cross is only paying $82, which is less than the 98 above. So one would think, why would we want to do this? And this was really why the CEO called me. Why, if we're getting paid $82, we know our fully allocated costs are 98. We have to walk away from this. But when we added these 50 tests, so watch what happens in the math here. So we add 50 tests here. We went from 1,195 to 1,245. All of those tests were commercial, paying at $82 a visit. Our fixed costs remain fixed. Our variable costs go up by $10 times 50 tests, or $500. Our Medicare revenue is going to go down because we just diluted our fixed costs over more units of service. So Medicare is going to pay us less. However, those extra 50 tests at $82 generated enough revenue where the bottom line improvement from these 50 tests is $2,200. If you divide it by the 50 tests, it was about $44 of profit per test that they generated. And again, even though they were being paid at a lower rate than Medicare. So here's if Medicare per diems are higher than commercial, should we focus on growing Medicare and decreasing commercial? So observations here. Medicare interim per diems are not actual. Just because we receive $1,500 during the year does not mean that that's what's going to end up in our pockets at the end of the year. At lower volumes, higher Medicare acute payer mix reduces losses. We showed that. At higher volumes, higher Medicare acute payer mix reduces profits. Break-even point for both models is similar when unit cost is equal to the commercial per diems. That was one we talked about that earlier. So what's the answer here? The answer is no, in most cases, unless the incremental contribution margin, in that $82 less the 10, that $72, that $72 has to make up for more than the dilution of your Medicare fixed costs. And so that's what this is saying. So most cases, 95% of cases, having that low paying commercial is absolutely critical to the profitability. And growing all business is important to reduce unit costs. Growing non-Medicare business is essential for profitability. We want to focus on inpatient volume or outpatient volume. I'm going to jump to this because we're running out of time. We're having such a good time. You guys awake out there? Anyway, so once again, let's look at the whole hospital now and say, okay, do we really want to? The one question about the Illinois administrator that said, boy, inpatient volumes getting paid 4 times what outpatient is. Let's just focus on inpatient. And so what we did is in that hypothetical model, we said, okay, let's look at the whole all in and let's just grow inpatient volume. And this was what happened to the profitability. We then said, let's just grow outpatient volume. Let's leave inpatient constant and grow outpatient. And what you'll note is at lower volumes, outpatient loses much more money. At higher volumes, outpatient makes much more money. And again, it gets back to payer mix. On the outpatient side, the Medicare payer mix was only, we assumed it was about 50%. On the inpatient side, it was about 85%. And that payer mix difference is what creates these differences in margin in this contribution. So the answer is, should we be focusing on inpatient volume or outpatient volume? And so some observations. Inpatient services are essential to covering overhead costs of the hospital. Matter of fact, this is one of the reasons I'm not very bullish on this rural emergency hospital, because if we give up our inpatient unit, we are giving, our inpatient unit pulls a bunch of overhead into it, and which is then cost-based reimbursed at 85%. You give up that inpatient unit, my gosh. Okay, let me move away from that topic. So focusing on inpatient services reduces both losses and margins, right? Because it's 85% cost-based. You can't lose that much when 85% of your business is cost-based. You can't make much either. You can't create positive margin. Focusing on outpatient services increases both losses at the low end of volume, and it increases the margin opportunity at higher volume levels. But it's necessary for incremental commercial business to generate enough margin to cover lost Medicare per unit revenue. We talked a little bit about that. So what's the answer here? Inpatient or outpatient? And the answer is both. Inpatient services are essential for covering fixed portion of overhead expenses on a very high cost-based payer mix. In addition, the incremental inpatient services pulls costs away from the ancillary departments that are heavily outpatient related. It drives down unit costs and allows you to create margin in the outpatient arena. Outpatient services have lower Medicare payer mix, thus enabling margin opportunity. And obviously, we must be aware of prices negotiated with third-party payers as they are critical. Next question. You guys ready? How do we want to look at non-hospital businesses run by a critical access hospital? This was an analysis I did years ago in North Dakota. And we just kind of said, like, let's look at the margin of all the critical access hospitals we're looking at. then check a box for the hospitals that have all of the different non-quote hospital to businesses, nursing home, assisted living, basic care, senior housing, ambulance, wellness, all of these things. And what happened is there was a very direct correlation between the highest profit critical access hospital with none of these. And as we increased them, our profit margin went down. So it doesn't bode well for what I'm going to say here in a minute. But so direct correlation between number of non-cost businesses and system-wide operating losses in most rural communities. Cause are the center of healthcare activity, and core mission supports these services. How do we think about this? And this is an example looking at home health, and I just want to walk you through it. So revenue is fairly straightforward. Matter of fact, most of the, all your Medicare revenue in this case is right in the cost report on your H schedules in the cost report. It shows you your Medicare revenue and your Medicare visits. We just estimated your other visits at 80% of Medicare payments. So here's your revenue, $600,000 for inpatient unit. You go to your cost report, and the salary expense, non-salary expense, right in your cost report worksheet A. Then there's a whole bunch of allocated costs get stepped down to through the cost report mechanics to the home health, leading to this home health has a $832,000 direct cost, right? Direct, allocated, total. If we subtract the total fully allocated costs from revenue, you come up with a loss of $232,000. However, a bunch of these costs, for example, admin in general, the CEO's portion of the CEO's salary is allocated to the inpatient or to the home health unit. If the home health were to go away, the CEO's salary wouldn't go away. So what we have to do is you have to kind of estimate that if the home health went away, what portion of these allocated expenses would go away, and they become more variable. So when we do that, we apply a factor, we come up with the variable allocated expenses of about $136,000. Total home health loss or costs are $680,000. There's still a loss of $81,000. There's one last calculation we have to do, because the difference between the costs that are currently allocated to home health versus just the variable, these costs, about $151,000, would get thrown back into the hospital and paid on an aggregate cost-based payer mix, approximately 35%. So all in, this home health, kind of loses that. If it went away, our estimate would be that our bottom line would improve by $135,000. We've got to do something with this. But these are the calculations that you should definitely think about when you're doing this. So how do we look at non-hospital businesses run by critical access hospitals? Important to understand pros and cons of non-reimbursable cost centers. They can generate margin. I was at a critical access hospital years ago, at a hospital in the Mid-South. They had 3 or 4 different sites. They generated about $2 million for this organization. So, some of the pros: mission objectives, potential direct gains margin, dilution of overhead costs to enable profit on commercial business. And cons, the direct losses and decreased Medicare reimbursement. So opportunities: understand true loss of non-hospital businesses by performing the analysis that we just looked at. We've got to consider the impact of allocating overhead over to this non-hospital business. If true net losses, after you do an analysis like that, it may be something we either figure out how to generate more volume, or cut expenses, or spin it out, or finally just recognize mission dollars towards it. So this is a very terrible question. So again, back to the questions, and we're going to wrap this up, from around the horn. So we go back, and again, our cost-based payer mix is nearly 60%. If we increase our expenses, we generate more revenue and margin. If we increase our expenses, we generate more revenue and margin. What this gentleman said is half right. If you do increase your expenses, you do increase your Medicare revenue, but you decrease your margin. Similar comment: why do we want to cut expenses if we lose revenue? Yes, you lose Medicare revenue, but you increase profit. because it's your non-cost-based piece that you generate incremental contribution margin on. The New York Critical Access Hospital Administrator, right? If we grow our census from 3 to 4, what this gentleman did not understand that by growing your census to 3 or 4, when you're 92% cost-based, is really that you're not generating any margin at all. Your revenue is going to go up almost in lockstep with your expenses. So there's no margin opportunity there at all. Illinois Critical Access Hospital, we just showed how important of outpatient is as it generates contribution margin and essentially profit. The New York, because of the negative impact on car reimbursement, we will no longer offer hospice services. Yeah, we just talked about that. On the Alaska Administrator, how do we grow outpatients radiology services when they're costing us $800 per study? What this gentleman was thinking about was that he was looking at the fully allocated costs and saying, boy, if we're only getting paid $700 from Blue Cross Blue Shield, but the fully allocated cost is $800 per test, we can't grow imaging. But he was not thinking about the fact that the variable cost and that contribution margin that was created is substantial and more than offset any dilution in cost-based reimbursement. My Medicare per diems are $1,400. My commercial per diems are $950. We're going to exit commercial to focus on Medicare. We showed how that was just absolutely the wrong thing to do. Anyway, so in summary, then we're going to turn it back over. The key takeaways of this presentation, in my opinion, volume is the key driver of unit expenses, and it also is most of our opportunities, because we have again, if 65% of our business is going by our front door, we've got to be able to pick that up. Commercial business, important source of profits, and profits generated on this must more than compensate for non-allowable costs. Costs are an important source of information, or fully allocated cost reports are an important source of information, but can be dangerous, because often we're looking at fully allocated costs rather than contribution margin. And so we got to be really careful. Interim reimbursement is not final reimbursement. Just because you're receiving a per diem of $1,500 all during the year doesn't mean that that's what you're going to get at the end of the year. And then the last is important to understand the pros and cons of non-reimbursable businesses. Understand the impact of third-party contracts on critical access hospital profitability. And I think the final thing that's most important is we can't let the tail of the cost report wag the dog of operations. We have to understand the tail, right? Because if the tail gets clipped in a doorway, that's going to hurt. But we don't drive all of our decisions off of cost-based reimbursement. And there was a CFO out in Wisconsin. He said, quality and service drive growth and finances, patient safety, quality, improvement, customer service, and not about the cost report. So with that, I want to thank you all for listening. That was just a ton of content. This is a much more of an interactive presentation than just me spitting out words for 55 minutes. But I appreciate you guys, those of you who stayed on, and turn it back over to Shannon.
Thank you so much, Eric, for sharing your knowledge as well as your time with us today. Also, thank you to all the participants for your time as well. I know it can be hard to carve out this time with everybody's busy schedules. So we do have 3 pre-post polling questions that Caleb just pulled up. If you could answer those before we conclude today's session, we would appreciate it. Just as earlier, your response options will range from confident to unconfident. As a reminder, the final session in the financial series will occur on Thursday, July 28th at 11 a.m. Central Standard Time. The presentation is on Rural Health Clinic Strategic, Financial, and Operational Best Practices with Ms. Opal Greenway from Stroudwater Associates. All the webinar presentations and the whole series of the recordings will be available shortly after the last webinar in the series, which is on July 28th. Also, just as a reminder, for those of you who would like continuing education credits, the center will be sending out an email upon the completion of the webinar series in which you may fill out. I do hope that you found this session beneficial. And as always, please do not hesitate to reach out to the center with any additional questions. And Eric, if you do have time, it does look like we received a couple questions. One from Mr. Kramer. Any thought on the new ops rule allowing for larger systems to integrate their costs more with affiliated cause?
Blake, I'm not sure what the new observation rule. I'm not sure. I'm not sure I get to understand the question.
Blake, are you still on the call? Are you able to come off mute?
Yeah, I'm here. It's in the new rule. It was actually in the same rule, Eric, where they released the REH proposed rule. It was in the OPPS rule that accompanied that.
The physician fee schedule rule. There's been 3 rules that have just come out.
This was in the same rule that had like the primary road definition and that type of stuff. There was some inclusion in there of allowing larger systems to greater integrate their costs with costs that were associated with them.
Boy, I didn't see that. If you want to share that with me, I'd love to take a look and see what you're looking at, because I went through most of that rule and did not see that. So that was the REH, that was the Rural Emergency Hospital conditions of participation. It was like 184-page rule. The last 10 pages were around the redefinition of primary road for critical access hospitals.
Yeah, I'll forward it to you.
Okay, great. All right, yeah, highlight the section because I'm interested in seeing what you got. Sorry about that. Thought I knew that.
Thank you. And once again, for those that stayed on the call, thank you for staying a couple minutes later. And Eric, just so you're aware, Dr. Pugh did put a lot of information. Thank you. And I hope you all have a great rest of your day and a great weekend. Have a good day.
Take care, everybody.
Thank you.
Y'all.
Bye.